Let me just make sure the screen sharing is working properly. And are you able to see that well?
Yeah, that's perfect. Thank you.
Okay, great. Thank you so much. By way of introduction, I was going to have a co-host for this session, Dr. David Gold, who works with me at Toronto Western as well. And unfortunately, he and his entire family are ill, so we're going to carry on without him. But appreciation to him for helping to get this presentation together. So obviously, my disclosures are simply grant funding from various sources. So what I'm hoping to be able to do today is just to carry on three objectives, and that is to understand the typical neuropsychological techniques and maybe some atypical ones for diagnosis and surgical prognosis of cognitive outcomes. So really this is going to be grounded in the surgical practice. And I will emphasize throughout that the role of the neuropsychologist is generally most focused or most useful, most unique in terms of the surgical prognosis piece. We also want to become a bit familiar with some specialized procedures for functional mapping, including fMRI and direct electrical stimulation that may not be happening in every surgical center, but in many across Canada, and to appreciate the application through the review of some specific cases for epilepsy surgery. But first, I want to give you just a very brief general background. So obviously, there's an interprofessional approach to surgical candidacy in all of our epilepsy surgery centers that has to do with taking a proper history, the EMU recording, which is going to tell us the information about the EEG correlation for the focus, an MRI, which will help us to determine whether or not there's a brain lesion or a brain focus of abnormality, the neuropsychological testing, where we're going to assess cognitive functioning of these brain regions, diagnostically to assess their concordance with the EEG and MRI, and prognostically to predict what is the risk from excision should that surgery take place. More and more centers are starting to use fMRI as a technique, usually for mapping language for lateralization and potentially localization of language, although also for some other sensory and motor cortices, and some possible additional investigations that we'll talk about in very minute detail, not minute detail, very sparsely, water procedure, invasive recording, intraoperative mapping, and MEG. So the conclusion of all of this very exhaustive and comprehensive investigation is to see whether or not we can identify whether this individual would be a good surgical candidate. And obviously the optimal one is someone for whom we've been able to identify the focus and we've been able to clarify that the risk of morbidity, especially on our side, cognitive morbidity, is minimal. So again, just a brief appreciation of what the neuropsychological piece of this is. Our approach starts with a comprehensive interview, then moving to hypothesis-driven standardized tests that allow us to assess multiple cognitive domains, some of them involving things like problem solving, attention, naming, or other language processes, learning, etc. So that allows us to develop in conjunction, to develop a cognitive profile that we can then integrate with the other medical investigations. So here I've simply put a handy little visual reference for you to say that we can group these into various kinds of domains like executive memory, speed of processing, attention, visual, spatial processing, and language. And in terms of bands of performance, is the performance average, below average, impaired, above average, superior? And this can give us a very quick little diagnostic glance to say, in this individual, there seems to be a fairly selective deficit or impairment in executive processes, not only in terms of the normative standards, which is how these individual bands are grouped, but also in terms of their other good cognitive skills. So it really does seem to be a selective weakness in this individual's case. And those kinds of findings then can help to inform the patient, help them to understand what their current weaknesses are, to guide the surgical approach that will help minimize risk to function, and potentially to direct rehabilitation efforts after surgery. So what's, let's say, the idealized profile? Now, I'm going to focus primarily throughout this discussion on temporal lobe epilepsy, For two reasons. One, we have the best evidence for temporal lobe epilepsy in terms of our own individual studies, but also multi-center studies. But also, it does turn out to be the largest cohort that is presenting to epilepsy surgical centers for investigation for surgery. And I want to just, of course, briefly remind everyone that in general, we're taking this in the context of the fact that the two hemispheres really are specialized for processing different types of information. Not unique, but certainly have a propensity for processing verbal information in the left hemisphere generally in most right-handed people. So what is often referred to as the dominant hemisphere, or at least the language dominant hemisphere, whereas typically the right hemisphere is more uniquely specialized for processing visual spatial information. So we take that into account. That's a very central consideration when we're thinking about diagnosis and prognosis in temporal lobe epilepsy, because our expectation is going to be that there may be some difference that we can detect between the left and the right hemisphere. So in particular for TLE, we're looking for selective memory deficits with generally intact performance elsewhere. Although a caveat to that is that naming and fluency or other verbal abilities are often reduced in patients with left TLE. And we're also looking for material-specific memory impairment and intact performance in the contralateral hemisphere. So again, according to my handy little cartoon here, this individual would have somewhat below average performance in memory performance and a little bit in language, but other processes are generally within the average or above average intact range. So this gives us a little bit of a clue that this is probably something to do with temporal lobe. And you're going to be seeing this chart a lot in the future. So this is one way that we can kind of visually depict when we drill down in terms of memory performance. Because again, now we're looking very specifically at memory, and we're looking at it with the view that we should be trying to separate out functions that are predominantly governed by the left hemisphere versus the right, or the dominant versus the non-dominant. So what I've plotted for you here are simply Z-scores, again, relative to the normative population data. And in blue, we have verbal memory tests or components of verbal memory tests. These are particular tests that we do at Toronto Western. There are other alternative ones that might be done in other kinds of clinics. But again, the general purpose is to say, let's try and isolate what's going on or look differently at what's going on within the verbal memory domain and the visual memory domain. And I'll also just briefly draw your attention to the fact that we generally think of some of our memory tests as much more core or pure memory abilities that might be really associated with specifically with the mesial temporal lobe, and some other kinds of memory tests or memory abilities that seem to have a greater contribution of other semantic or executive type function. But nonetheless, what would we hope for in this idealized profile? We'd hope to see that verbal memory is relatively weak, visual memory, visual spatial memory is intact, which would tell us, yes, this person probably has, or I should say this neuropsychological profile is quite concordant with what else we know about this patient, that they have a left temporal lobe focus, for example. So that would be what we'd be looking for in terms of the idealized profile. However, in real life, rather than idealized profile, over the last number of years, there's been quite an exploration, I should say, of the different kinds of cognitive profiles that one can see. And they're not always ideal, so we always have to keep this in mind as well. So this nice study by Annie Reyes et al. Looks at, again, a number of different domains, in this case, memory, some tests in language, and some tests of processing speed. And they applied both kind of clinical grouping of individuals and also a data-driven clustering algorithm to group individuals. And what they found was that in this sample of 400 people appearing at epilepsy neuropsychology clinics, that about a third of them were of the generalized type. That is, they had impairments across the board here. You can see these dark bars across all of these domains. They had about a third of them with specific language and memory impairments, so more the temporal lobe profile it would be looking for, and about a third of them looked perfectly intact relative to healthy controls. From the normative databases. So again, this tells us that we've got some degree of complexity that we're going to be having to contend with in terms of the patients who are coming into our office or into our clinics. And at least in this particular sample, they were able to derive a couple of clinical features that seem to be associated with this. So for example, in the no impairment group was more likely to have higher education, and the individuals with generalized impairment were more likely to have a longer duration of seizures. But of course, we know that cognitive impairment can be, or cognitive functions can be affected by a whole host of things that come with an individual packaged together with the individual with epilepsy. Some of it is their seizure history, some of it is their age, some of it is their education, some of it is the medications that they're taking, some of it is their educational experiences that they may or may not have had because of seizures starting early in life, et cetera. So it's not terribly surprising that these clinical phenotypes might actually be a little bit outside of what one might have imagined from the kind of standard textbook of what you should expect with damage in one particular area of brain. So there are a couple of different ways of dealing with this kind of complexity, and I'll talk about some more at the end, but this is one way that our clinical practice, we have tried to do this. So you might appreciate from here that in fact there are a number of different measures that feed into each of these domains. For example, memory language processing speed. Here, there are a number of different tests that feed into each of these verbal versus visual spatial memory factors. And so rather than trying to teach our trainees or understand ourselves to how to use our special neuropsychological eyeballs to figure out how to work with all of these data, a number of years ago, a decade ago now, what we tried to do was to say, let's take the memory tests that we think from our clinical experience seem to be very helpful in identifying left dominant and non-dominant hemisphere memory dysfunction. And let's use a principal component analysis to try and reduce these to individual scores so that we can now, anyone who's trained with me over the years knows my standard kind of rubric of anybody can fail any test on any day for any reason. So we know that individual measures or individual scores might be less reliable than looking at a component factor that might actually capture some of those underlying dimensions with the ability to capture them in a more unique source of variance as opposed to all of the other things that sit on top of your verbal memory function. So we included IQ as a kind of general cognitive capacity, and then a number of 3 different measures from visual spatial tests and 3 different measures from verbal tests. And here's our solution from the preoperative data, and here's our solution based on postoperative change. And so this was based on about 65, I think, patients at the time. And we felt like we had a fairly good resolution of those components and their ability to pull apart those particular domains successfully. And then we said, well, okay, now we're really not only interested in saying, does this help us with diagnosing a problem, but how can we use this to help counsel patients, help predict what's going to happen to memory following surgery? And so we wanted to say, what's the relationship between your score? And here I'll just try and tell you, you can think of these as pseudo Z scores in terms of the population that we entered into our principal component analysis. So a high score means you're doing very, quite well relative to that cohort, and a low score means you're showing a lot more deficit than that cohort. And here we see that we have a reasonable correlation between how well you're doing ahead at the baseline and the degree of change that you can expect following an anterior temporal lobe resection, both for the verbal memory score for the left TLE patients and for the visual spatial memory score for the right TLE patients. So, and this kind of aligns with our general rubrics that we've used over the years, over the decades, in terms of if it's working well, taking it out is probably going to cost you something. I mean, that's the shorthand of this. But what we tried to do was to put a little more meat on the bones for that kind of algorithm to be able to give us somewhat better prediction power. And so how do we use this in practice now? So for each patient that comes into our clinic, we do, we calculate our specific hemisphere-specific PCA, so our verbal memory, our visual spatial memory, and our predicted PCA change. And from the original paper, simply what we did was to kind of divide them up in terms of quartiles. So the people who showed the biggest degree of change versus the people who showed the least degree of change, okay, following that respective surgery. So this hopefully allows us to take the PCA predicted change for an individual and be able to talk with them about, well, here's kind of the magnitude of change that we might expect from you. Of course, telling them that information is something that they need to be able to take into account. And as we'll talk about later, individuals will certainly have different weightings in terms of how they value that bit of information relative to other sources of information or predictions of outcome in terms of seizures, et cetera, when they're making their decision as to whether or not to undergo an elective resective surgery. But we feel that this at least gives us a little bit more power to be able to assess the domain with a little bit more fidelity, because we're not trying to, again, use our special neuropsych eyeballs to look over a number of different test characteristics, and also to be able to counsel them in terms of the general kinds of changes that we see. And I will just say, kind of off the cuff, that this obviously doesn't tell us the degree to which any of the individuals in our original sample said this was a clinically meaningful change for them. This is all still strictly based on the neuropsychological test data. But over the years that we've done this, the clinically meaningful changes often occur in terms of the first quartile. So individuals who are predicted to show and who do show a change of this kind of magnitude are the ones who will at least come back and say, I had a noticeable change in terms of my memory function. And I suspect it won't surprise anyone that the vast majority would be talking about verbal memory abilities. Visual spatial memory abilities don't seem to have the same resonance often with individuals, unless that might be a domain of function that's really particularly important for their job performance, quality of life, et cetera. So this is one of the techniques that we've developed over the years. And I'll say that because this was based on, again, a relative sample of tests, we're now trying to redo this PCA with some additional measures that we have to see if we can do an even better job at being able to characterize cognitive risk. But we do feel like this gives us an opportunity to have that conversation, both with the patients and also with the epilepsy surgery team to give a better estimate of the magnitude of change we expect. So I'm going to spend the next couple of minutes and slides talking a little bit about fMRI. And again, not done in every single center for sure. I've been doing this since probably about probably 20 years now. And many centers in the US are doing it. In fact, I would say that for the vast majority of cases, in the vast majority of institutions, fMRI has completely supplanted sodium amytal or WADA testing for determining language lateralization when that is critical. And certainly it is much better for determining language localization when that is critical. And that can often be critical, especially in cases of structural lesions like tumors. So I'll just give you a little bit of an insight into how it's done in our center, and I think we're fairly comparable. So again, we're the primary reason that it's used is for language lateralization and localization. And as I said before, it's very crucial for us in the temporal lobe epilepsy world to be able to tell which hemisphere seems to be dominant for language, or if in fact there's bilateral language representation, because that will definitely impact our understanding of both diagnosis and prognosis in an individual case. So generally what happens in an fMRI is that an individual, while undergoing scanning with a special sequence, undertakes an active task and a control task in a kind of interleaved fashion, 20 seconds of one, 20 seconds of the other, back and forth, et cetera. And the task can be quite varied. Different institutions use different ones. We typically use 2 or maybe 3. So sometimes it could involve something like complete the sentence. Just think about a word that you could put in this sentence at the end of the sentence. Sometimes it's define what's the definition in your head. What's the word that fits this definition? Or sometimes more complex operations like tell me whether or not these 2 words are synonyms or mean the same thing. And then the control task is designed so that you can basically take away some of the uninteresting things that are accompanying your delivery of the stimuli, like visual processing. And so you use control tasks that contain visual information, and critically, you try and use control tasks where people are not trying to think of words, basically. So you really want to minimize the language expression or comprehension on the control side. And you can see for an individual person here, the top bars, the ones with the bars at the top are showing where this activity is increased when they're, sorry, I shouldn't say activity. We're not measuring neural activity directly. We're measuring a very indirect measure called the BOLD response, or the blood oxygenation level dependent response, because it turns out when neurons are active, they require a lot of oxygen to be delivered. There's more oxygen than is needed in that particular area, and deoxyhemoglobin turns out to be a paramagnetic substance. And so we can kind of measure indirectly what we think is happening because of this BOLD effect. So you can see that the pattern goes up and down in particular areas. And those particular areas are ones that we then understand to be critical for language function. So in this case, we have 2 different tasks, and we see very nice, canonical inferior frontal, middle temporal, and superior temporal or Wernicke's kind of area. And we also typically see lateralized activation patterns in supplementary motor areas. So this would be a language lateralization task. Why do we think that that's useful? Well, it's useful for a couple of reasons. And why do we think it's valid? Well, one nice study, and this is actually one that capitalizes on other studies as well. So it's been shown in other populations. But you can see that the asymmetry of activity, so more on the left side, if everything was active on the left and nothing on the right, you'd be close to 100. If you had complete equipoise in terms of activity in both hemispheres, it would be 0. And otherwise, it would be down here where we would say you have right hemisphere dominance. And you can see that in general, the degree to which you are naming performance changes following surgery. So 0 means you got exactly the same score before and after surgery. Anything down here means you actually, something you could name very easily before surgery, you now are struggling with. And so that lateralization really does tell us information that is useful about the functional capacity of that tissue. And then the other thing, and I'll spend a couple of cases just to illustrate this, is that you can actually use these activation maps to help you guide stimulation mapping, either in the OR or in SEEG. So let's just go through a couple of quick cases in that respect. So case number 1 is the question often arises, is bilateral language protective? So we sometimes feel at quite a disadvantage if somebody really shows strong bilateral activation to be able to say, oh, well, here's what we would expect to see following your surgery on your left temporal lobe, for example, because we just don't have a great deal of evidence in that regard. There's some evidence, but not a great deal. So this is a 29-year-old female, actually didn't come through the epilepsy service, she came through the brain tumor service, a newly discovered gliomas in the left parietal, which you can see easily here, and a smaller one in the left insula frontal lobe. She actually had no symptoms of language disturbance, and even on clinical investigation with brief aphasia screening, absolutely fine. And as you can see, our language maps actually show a fairly strong bilateral pattern. So she shows the canonical areas in the left hemisphere, inferior frontal and middle temporal gyrus, but she also shows some of those canonical areas in the right hemisphere. So in this case, and even in the supplementary motor area where we actually see bilateral activity. So in this case, in consulting with the patient and with the surgeon, we could say this might be somewhat protective for her, especially as she hasn't really noticed, even with, this was an incidental finding because of headaches. So she didn't even come with a seizure. But we thought, there's some chance that she might actually have relative preservation relative to other individuals for if you do this resection in this region that we know have important language functions in terms of angular gyrus and superior posterior parietal, inferior parietal lobe. So here's her actual resection. And during her stimulation mapping, we actually didn't map to the depths of the lesion, just on the cortical surface. And she didn't have any disruption to naming or calculations on that mapping. But she did postoperatively have a notable motor and phonological aphasia. This actually recovered fairly well with speech and language therapy after her surgery. And the open question is, would she have been in, worse shape? Would she had suffered greater language morbidity had she not had that language capacity on the right hemisphere? And there are ways that I think we should be moving to test out some of those possibilities, but in this case, we didn't have that available to us. Sometimes we are asked to look at things that go outside of the language domain. So I'm going to show you a couple of cases of that. So here's an individual with who did come through the epilepsy service, a posterior quadrant epileptic zone. He had focal aware seizures with a lot of visual auras, as you can see here. Many of them progressed to impaired awareness with automatisms. His MRI was indicated to show a possible small scar or possibly periventricular nodular heterotopia in the posterior horn of the right lateral ventricle. His scalp EEG localized to the posterior quadrant with a rapid spread to the right anterior temporal lobe. And his neuropsych assessment was fairly bland from the respective of posterior quadrant function. We did find him to be left hemisphere dominant for language and also showing memory deficits for both verbal and visual spatial material, although the neuropsychologist thought at the time his depression might be playing a role in terms of those memory deficits. Okay, so in this case, we did MEG, and it showed 4 independent spike foci in the right occipital and temporal regions that were modeled by Dr. Wenberg in our group. And one that really concerned us a bit was this region here, where we thought it really might overlay or be coincident with the fusiform face area. And as you see in this little cartoon here, there are a number of regions of the brain that are selective for faces: fusiform face area, occipital face area, and anterior. And I have to say that we're particularly sensitive to that in our practice here, having had 20 years ago or so, an individual who did suffer profound prosopagnosia following an extensive right temporal resection in that area. So we're very keen to make sure that we understand what's going on there. So we did a couple of tasks. I'm just showing you one here. And this is one where the on task or the active task is showing individual faces, and the control task is showing kind of distorted faces, so visual images. And what I think you can appreciate is that we do see fusiform face area, but only in the left hemisphere, which is kind of interesting because in general, it's bilateral or predominant in the right hemisphere, and in bilateral in the occipital face area. So this gave us reason to say, well, we know this patient's going for SEEG because of the 4 different foci. We need to get a handle on whether or not any of this is operable. And so let's make sure that during stimulation, we can actually do stimulation with faces as well. So I'll cut a little bit to the chase because of time, but you can see here an overlay of one of the electrode sites. There were multiple in the SEEG implantation. This one was called the right basal occipital, which kind of is coincident with this region that we were interested in. I'll skip to the mapping where we used an Amsler grid, which just allows us to look at whether or not there's any kind of visual distortion, and also famous faces. So we used faces that this person could name right ahead of time before we started stimulation. And what was really most interesting was that when we stimulated in the more superficial contacts of this electrode, there were delays in being able to name these. And in fact, the individual claimed that it was like looking at faces was looking at like a Picasso, very distorted. And interestingly, it was very specific to faces because we had him try visual objects and there was absolutely no problem with being able to name those. So we felt fairly confident that we were actually in the face area. And the plan, given all of the complications of multiple different foci, et cetera, was simply for medical management. But should that, it was very helpful to be able to know that should there be no reason to avoid this area from surgery from a epilepsy perspective, that there might have been a significant cost. Okay, and I'll just do one more quickly before I head on to other neuropsych cases. Again, another case with a visual cortex epileptic zone. Just quickly want to say that left hemisphere dominant for language, no focal lesion. Neuropsych was interesting because there's actually a 20-point split, which is a pretty dramatic difference between the visual spatial functions and verbal functions captured by the IQ testing. And he also had a slight homonymous hemianopsia on visual field testing. Again, Meg revealed this, temporal occipital single seizure that was able to be modeled in this area. And so implantation was done. Just want to show you that this area in particular is interesting to us because it kind of corresponds with an area that we know that we think of as a visual motion area, V5 or MT. So in our specially designed task here, we show either a visual checkerboard to get primary visual area activated or moving visual stimuli. And you can see this MT area really looks like it's coincident there. So we were able to do SEEG mapping. Here's the little location of that seizure that was identified. Here are our activation blobs, basically. And what we could notice was that, again, when we were mapping in this area, he would see in the deeper contacts some distortions in the upper left field, but with the more superficial contacts in this MT area was actually seeing a movement of light in the upper left side. So again, telling us that that was an area important for motion perception. And this individual is still considering his options. I think I glossed over the fact that this person actually is involved in film and was reluctant to have any visual disturbance. Okay, so I'm going to leave fMRI aside, even though it's my dear love, but talk to you for the next 10 minutes about more of the kind of meat and potatoes neuropsychology for a couple of different cases, and again, how this can have an impact. So we'll start with the typical one. Again, the idealized one. We want everybody to walk in exactly like this so that we can do our job in the most efficient way. A single individual, 36-year-old, relatively short duration of seizures, but very typical semiology for a temporal lobe epilepsy, high average IQ individual, does have left mesial temporal sclerosis. EEG says left temporal focus, anterior temporal focus. Okay, so two of our indicators, EEG and MRI, say this person might be on a good surgical path. And the neuropsych profile says, hey, this person is on a good surgical path because it's very coincident and we don't predict a lot of change. So our verbal memory scores do show that much weaker. Again, this is a high IQ individual, so relative to herself, we would expect her to be quite good in this domain with a perfectly intact and therefore well-preserved the right side, the non-dominant side. in terms of memory. And when we do our PCA analysis, we see that her pre-op score is a kind of almost a standard deviation down. So she's right in the ballpark of where we expect left temporals to be. And our predicted change is actually a slight one. So we thought she was a great candidate for surgery. Turns out she went for surgery. And in fact, in red here now we see our post-op scores. And you can see that actually not a huge change in terms of memory, although we do see a change. This word recognition test is one of the ones that goes into our PCA analysis. So she did actually show, standard deviation or a 1.5 SDs change on that direction, and a bigger change in terms of a relatively newer test of name recognition that doesn't form part of that PCA analysis at this time. We are adding it in. So at any rate, we had a predicted change of 1.5 or 0.15 units, and the actual change was only slightly more than that. Nonetheless, she remains seizure-free, no significant cognitive changes that she's noticed other than a little bit of difficulty with name recall. Again, recalling people's names is very common with a standard left anterior temporal lobe resection, because we know that the temporal pole region is a kind of hub for proper names. So that's a very common complaint, but we also were able to pick that up on a name recognition test here. But nonetheless, this is if everybody came in this way, we wouldn't be sweating bullets usually in the clinic. So let's now look at an atypical memory profile and what happens under those circumstances. So again, 24-year-old male, 15 years of education, a little bit more prolonged seizure history, very compatible with temporal lobe epilepsy, again, left MTS, EEG left anterior temporal focus, fMRI says left dominant for language. Okay, so far our indicators are lining up just like our last patient. What happened when we look at his memory? Oh, this one is a little bit more complex. So what we see is that his verbal memory profile is actually his best scores. He's doing as well, or in some cases, slightly better than the average individual relative to population norms. And in contrast, his visual memory indicators, except for this one score, are actually weaker. So this is very uncommon, typically in individuals who are, strongly left dominant. But nonetheless, we said, okay, so what does our PCA analysis tell us? Well, it tells us he's actually much better than the standard left temporal case, and he stands to lose more than the standard left temporal case, or certainly more than the last patient that we looked at. So what did we think about? We said, well, this profile is flipped. It looks like the left side is his strongest side in terms of memory, or his dominant side in terms of memory. And so he should have a significant decline, but we also had a bit of a question about the functional reserve of the right hemisphere, given that those scores were poorer. And so under the rubric we were using about 7 years ago when he was through with us, we thought we would proceed to a WADA or automate an ECM test named by the M&I folks who developed it with Automate. So basically, if you've never seen one and you're less and less likely to ever see one in the future, you give an injection of the drug, which is an anesthetic agent that travels to the MCA and ACA territories. While the drug is on board and EEG is slowed, you present, in our case, 10 memory items, very common items for them to manipulate. When the drug is cleared, we say, did you see this item? Did you see that item, et cetera? So we test for recognition memory. What happened with this individual? Well, first we inject the side to be operated, okay? And that looks at the functional reserve of the other hemisphere. And he gets about 95% correct. Then we inject contralateral. So now we're looking at the adequacy of the tissue we're about to remove, and he gets 100% of the items. So that's quite concordant with what we understood from his neuropsych testing. His verbal memory is stronger than his visual memory, but we were quite comforted that there wasn't going to be a catastrophic problem with this individual, because he had very good reserve on the other side. And so we did still expect there to be a significant memory decline, though, because that's a stronger memory side. What happened? Exactly what we predicted, or else I wouldn't be showing you this case. But I think it's a good illustration for other reasons. So if you look at his postoperative scores, every single verbal memory measure went down. If you look at his non-visual spatial memory scores, they basically stayed pretty much the same. So we predicted a change of almost a pseudo Z unit of 1. We got actually an even bigger change than we predicted. So what happened with this individual? Well, this is a really good lesson for neuropsychologists that we don't necessarily always have to, we respect the numbers we come up with, but people are more than the numbers that they produce for us. So this individual was seizure-free at 2 years post-op. His much improved in terms of his life. He's more socially involved. His mood was better, back at work, and he had absolutely no cognitive complaints when we did this post-operative testing. So goes to tell you that what's important for the patients is giving them the best information you can, but even in the cases of really quite significant memory changes that were predicted, it may not outweigh the benefits of surgery. And this is the last case that I want to talk with you about. And this is one I think that's really helpful to illustrate what's most important to the patient. Again, taking off from the last case. So this was a 32-year-old left-handed female. She's a clinical psychology student, and throughout the course of the investigation, she was very, very concerned about losing any verbal abilities at all. She wanted to become an academic, and this was just absolutely critical to her. Again, a relatively short period of seizure history, classic temporal lobe seizures, left MTS, and left temporal lobe seizures. So what did we hope for her? Well, what we hoped for her was what we actually got. So her fMRI actually showed very strong and compelling right hemisphere dominance. This is still relatively rare, but she is a left-hander, and so many more left-handers show right hemisphere dominance than right-handers. I apologize for the colors. I actually had to borrow this from Dr. Gold, and so I don't have the original raw data to replot. But at any rate, what I wanted to draw your attention to, first of all, very consistent with here, even though she has left MTS, all of her verbal memory measures are great because her verbal functions on the right side, and all of her visual spatial memory measures are poor. And importantly, this Boston naming test, which is one of the measures of verbal functions, was quite good. We were able to talk to her and say, look, we really don't have any concern about these really important verbal measures, verbal capacities in your case, because we have confidence in what's going on these tests, and we don't think you'll show a hair of change. And essentially, she didn't show a hair of change in terms of her verbal memory performance, and she got a little bit worse in terms of visual memory skills, because again, we were taking out some tissue that was important for visual memory function. So that tells us, again, listen to what's important to your patient, and if you can bring to them something that will be really helpful for them to appreciate in making a decision about surgery, that's the secret sauce that makes it the best experience. So I'm going to share this slide. I don't want you to take in the busy slide at all, but I really want to share the reference with you, or the citation with you. This is from a colleague, Bryce Mulligan in Ottawa. And he's provided us with a very formalized kind of approach for taking what a patient comes in and says is the most important thing to them, like our patient who was saying, I really need to preserve my verbal abilities, or perhaps the most important thing for me is to be able to drive again after surgery, and really go through an iterative process by examining the literature that allows us to, compute some kind of likelihood ratio of what the likelihood of that is to happen should you undertake that surgery, based on what we know about you and what we know about the general population, and then enter into a collaborative kind of decision making where you can say, here's the kind of degree of risk that we think is posed to you if you undertake that surgery. So again, I know the slide's terribly busy, but do copy down Bryce's reference because I think it's a great way of being able, again, to formalize how we can discuss with patients. And so I'm just going to allude to the fact without too much, because I know I'm out of time, just to tell you there are some newer strategies now that we're trying to evolve to predict outcomes. We have, some measures or some ways that we can do this. This work from Robin Bush and her colleagues, multi-center kinds of studies. We've been involved in some of them to be able to generate what we call nomograms that, take based on models that have been developed. We are able to say assign different point values to performance on various cognitive tests, along with information clinically about site of resection and whether the hippocampus will be resected, and then use that to calculate a total points and essentially give people, again, a quantitative value that tells you, okay, your risk of a clinically significant change in memory is 50% or 80% or 10%. So these are one way of doing that, using the clinical score, cognitive scores and clinical data. And then one way that we've been trying to do that, and again, I won't go through this in any detail, but happy to come back and give a separate talk on this. But one way that we've been doing is to try and take what we call resting state fMRI and to look at how the connectivity of these networks, either in language or memory, how they compare to a healthy control that we generate a template for, and then derive a couple of different measures. One, how well the rest of the brain is working in terms of that, the connectivity amongst those nodes, and another, how strongly that part of the brain that's going to be removed is integrated with the rest of the network. And we can derive these two scores that actually combined explain 44 to 6% of the variance, and actually do a better job than some of the other measures that we currently use. So I think that leads me to my final kind of reflections rather than conclusions, because this is an ongoing enterprise. So I won't conclude, I will reflect. That neuropsychologists in epilepsy contend with, from a neuropsych perspective, a host of what we call confounders. And I was sharing with Robin that there's a healthy discussion about what do we do about topiramate, because it actually affects, we know that it has an effect on language functions, and that could give us false lateralization, et cetera. So we have a lot of different factors to kind of put in the mix relative to the kind of standard functional neuroanatomy textbooks that we have to contend with. I want to say that we have continued evolution of these techniques for assessing function and, importantly, predicting postoperative outcomes. Interprofessional practice remains a cornerstone of this disorder. We can't do it without our colleagues, and I know that our colleagues really value the added information that we can provide for the patients. And as always, the individual candidate remains at the center of the process, and learning how to understand and appreciate what's most important for them is a skill, that we all always need to constantly guard and develop in our clinical practice. So with that, I will stop sharing and happy to take any questions.